We're not going to pick on you today. We will just... Right, so welcome to Kdsg, our 11th annual scientific conference. This is the foot workshop, so we will be talking about everything foot. We'll mention about podiatry, we will talk about wounds, we'll talk about the surgical aspect of the diabetic foot, we will talk about offloading. I have a very accomplished team with me today. So we have Hafsa Khalid, who's a podiatrist like myself. We have Dr. Samir, who's our podiatric surgeon, and Dr. Shilpa, who is our endocrinologist. Okay, so we will be addressing podiatry, and my job is just to introduce podiatry to you. So one thing I want you to do is I want you to just stand up, please. Stand up, please. Right, now I'd like you to all stand on one leg. Stand on one leg. And now I want you to change places with the person you're sitting next to, but on one leg, and you're not allowed to touch that person. So you can't hold on to anything. You just have to change places with the person you're sitting next to. Okay? How long did that take, everybody? About 20 seconds? So imagine now you're a person living with diabetes who's had an amputation. How easy would that be, and how much your quality of life would be seriously rescinded? So this is why diabetic foot complications are so important. So my job is just to introduce the team, which I've done, and then to talk a little bit. So we talk about the history of podiatry. Podiatry is a specialty, you can sit down now, please. And you can stand on both your legs again. So the history of podiatry has been around since the 1700s, okay? And it's only been in the last sort of 20 years that it's become a regulated health profession and is now mainstream, or it's a specialist niche of medicine, but now is very much at the forefront. And particularly that's more so than we're dealing with the diabetic foot. Do you know that a person will develop a DFU every 2 seconds somewhere in the world? And one leg is lost every 20 seconds to diabetes. And 85% of these are preventable with just simple care. How much of you, how expensive do you think it is to deal with a diabetic foot? Well, let me give you some facts. It costs 2,000 to 5,000 shillings to examine a patient living with diabetes for diabetic foot complications. If you end up with a DFU, it's 5,000 to 10,000 shillings every time you have a dressing. It's 30,000 to 50,000 shillings if you end up being hospitalized due to a diabetic foot complication. It is 200,000 to 500,000 shillings if you end up with a BKA or an AKA. And for remodeling of a foot using vascular services, you're looking at up to 2 million shillings. So that is why diabetic foot needs to be addressed so much in Kenya. Okay, so let's talk a little bit about, oh, sorry, my cursor has, okay, so let's talk about the burden of diabetic foot in Kenya. Diabetic foot-related complications, you can go to the next slide, thank you. I think, yeah, there we go. So when we talk about, let's talk a little bit about podiatry. It's a medical profession devoted to the study and medical treatments of disorders of the human foot. We are the only medical professionals who exclusively specialize in the foot and ankle. So if you have a knee problem, we can't help you. Okay, so let's just go back. So this is podiatry in Kenya. Basically, that's a baby picture of me. This is when I actually had hair. And I must have been about, I don't know, about 25 at that time. And we had a project with WDF that was funded by DMI, and also we worked with the Ministry of Health. And we ran a 3-year project where we tried to educate people in different counties on how important diabetes was. And the goals was to raise awareness about diabetic foot problems, to set up foot clinics in existing diabetic areas of hospitals, And we also, to reach remote areas, we set up an MFC van where we could then reach all these areas to help people who couldn't afford services. Okay? So when we talk about diabetic foot in Kenya, this was something we did at KNH, and 4.6% were found to have diabetic foot ulcers. Foot ulcers occurred in those longer duration of diabetic patients. You know, the occurrence were 47.5% were neuropathic, neuroischemia 30.5%, and ischemic 18%. Neuropathic ulcer group was significantly poorer in people with poor metabolic control. The ischemic ulcer group was significantly higher with cholesterol and blood pressure issues, amongst other groups. Okay, so in conclusion, the prevalence of diabetic foot ulcers were about 4.6%. If we're talking about 1 in 11 patients in the world are diabetic, then we're dealing with diabetic foot problems, and if we look at 15% of those will develop a diabetic foot ulcer at some stage in their lives. Okay? If we're talking about a burden of Kenya, we talk approximately 3 to 4% will develop a diabetic foot problem. And out of those, 50% of lower limb amputations will develop in patients over 60 years old. Okay? And the higher costs are often associated with prolonged stay in hospital and the need for home care nursing. Okay? So these are the challenges we face. Cost of care. I've just talked to you about cost of care. They present late. They don't have appropriate footwear. This is a big one. Okay? Alternative medicine. People stop taking their oral metabolic hypoglycemics and they end up going to sort of drinking tree bark and, I don't know, using funny soaps and all that stuff. Social habits of barefoot walking and poor follow-ups. And then we've got clinical inertia as well, lack of podiatry services. There are 8 registered podiatrists as of now in Kenya, 8. Just 8, okay? So, and then resources and inadequate training as well, and poor access to facilities, okay? But we are adapting. We're adapting to the IWGDF guidelines. We're setting up conferences. Like this one. We are also hands-on workshops. We've got panel discussions, and thank you for all attending this one. Screening for risk. Sharps debridement, which you know is the gold standard, and I'm sure Kennedy, our tissue viability nurse specialist who's lecturing to us today, will talk about Sharps debridement. We're talking about an MDT approach, multidisciplinary approach, and surgery when needed. And thank you, Dr. Samir, for agreeing to present to us today. He's our first registered podiatric surgeon in this country. So we're happy to have him. And then you're talking about research. You know, in Kenya, we're very good. We've got boots on the ground, but it's collecting data. It's collecting data so that we can show and get more internationally recognized. Okay? So this is our organization. This FALGA is like Kdsg of the foot space. So it's known as the Foot and Limb Group Association. We are married also to government, so we sort of work with government to set up sort of webinars, training programs, and as of now, we are setting up a certified course, and we are setting up, so for nurses and people who would like to go into the foot space, we have what they call a podiatric foot care assistance course. It's a 2-year higher diploma, and we're going to base it with KMTC. So you can, and it's a standalone CADA, and you'll be under podiatry. We're setting up hands-on practice because podiatry is all about hands-on practice. Symposiums, patient education, and FALGA is working to ensure that every health worker in Kenya has the knowledge and the skill to protect the patients from devastating effects of diabetic foot disease. So this is the team that we're going to talk to you today. So I'm not going to go through it, but we have our podiatric surgeon, and thank you. We've got Dr. Shilpa, who has been in the foot space for a long time now, and she's instrumental in helping set up the Lions Center for Excellence for Diabetic Foot and Wound. clinic. We've got Hafsa Khalid, she's a podiatrist, she works with me as well. We're sort of joined now and she works with me. And then we've got Kennedy, who is our tissue viability nurse specialist. There's no one better who deals with ulcers than this man. You have any ulcer, he will tell you what it is. So the human foot is a masterpiece of engineering and a work of art from Leonardo da Vinci, okay? So thank you, guys. And let's try to stop the domino effect of diabetic foot complications, and let's put all the pieces of the puzzle together. So thank you very much. My name is Fabian Collis. I am a podiatrist. I've been around. Some people call me the grandfather of podiatry. I am older than I look, probably, or young, or that, the other way around. But thank you for coming here, and we're in for a treat with all the presentations. So thank you, guys. Cheers.
Good afternoon, everyone. How are we? Are we sleepy? Shall I ask you guys to hop over once again? I for sure could not do it. It was terrifying to think what would happen if I had to wear this and then do that. I tried. It was not possible. And that is what we feel for our patients as well. So what are we going to do for our patients from wound care to outcome, right? So I am going to talk a little bit about a few cases. I've kind of put together 5 cases from our center at Lions Side First Eye Hospital. No, Lions is not just an eye hospital. We have an exclusive diabetes care center. We have a foot and wound clinic that was initiated by Dr. Fabian, and we've worked together to build it to what it was. I'm looking to one of you to take it even further one day. I want to talk about limb salvage today, vascular disease, adjunctive therapies, and a little bit of money, money, money. Right? Are we up for it? Doc has already talked about the mortality in regards to diabetes-related foot. This is disconnected. Okay. He's talked about it, but I'd like to reiterate so that it is impactful for you. If a person undergoes a major amputation, within 5 years, they have 50% mortality, and most of the times within 10 years, it is 100% mortality. Losing a limb is not just losing mobility. It is about the loss of the ability to be independent in most cases. How many of you have been able to encourage a person living with diabetes who's undergone a foot amputation or a below knee amputation to take up a prosthetic? How many of us have done that? You have. How successful is it, Samir? Does it take some time? It takes time. And in all that time, they've lost their functionality towards whatever role they were playing in, whether it was in family, whether it was at a workplace, whether it was a teacher who was teaching students so well, or even if it was a clinician or a doctor, like Dr. Fabian has dealt with. There was an ophthalmologist that he often talks about who we were unable to do a limb salvage for. And the cost implication is immense. By 2045, the entire continent's diabetes-related population, people living with diabetes, we just had this conversation in the morning where we don't say diabetics, we say persons living with diabetes. The population will double. Africa is undergoing a rapid epidemiological transition, and it's driven by urbanization. We like to mimic the West in many ways, but in some ways we can't help but mimic the West. How many of our great-great-grandparents ate bread? How many of our great-great-great-grandparents ate even ugali? We stuck to eating vegetables, and I'm not just talking about the context here in Nairobi. I am also Kenyan. I'm born and brought up here. But even if I think of a similar context, as we call it the global south, even in India, rice was not something that we ate all the time. Where I come from, rice wasn't something that we ate. But urbanization and trends and life happened, and we had to change to what is easily available. Colonization happened, right? It shifted a lot of things in our day-to-day. And the unfortunate thing is that 79% of the diabetes-related deaths are happening in adults under 60 years of age. Is this an economic drain for the country? Of course it is. And that's why we struggle. It's a whole missing demographic of age. So, and the medical bills are not just the tip of the ice. The medical bills are just the tip of the iceberg. When I'm talking about health economics and how, because of our adaptation and our new predisposition to diabetes, we are seeing that it's not just the medical bills that pose a problem. As you can see, it's drugs, diagnostics, all of that is the direct cost. What of the indirect costs? What of the permanent disability that this individual has to face for the rest of their life? What of the loss of income? What of the premature mortalities that they face? Apart from that, imagine their day-to-day lives. It is impactful to have to undergo an amputation. Chronic care is fundamentally incompatible with out-of-pocket financing. We are spending too much from our pockets also because our governments cannot support it entirely. I want to rush through a few things. The vulnerability. Why is it that we are prone for diabetes-related foot? This time we decided we are not going to talk about pathophysiology. You know about neuroischemic ulcers. Who has a question about neuropathic ulcers? Who has a question about ischemic ulcers? We all have an idea. These are familiar faces. Most of you have attended these foot-related workshops before, and I appreciate that you have returned to learn a little bit more from us. But we've talked about neuropathic ulcers, ischemic ulcers, neuroischemic ulcers. So just to give you a quick overview, the vulnerability is that the person has peripheral neuropathy, lack of vascularity, ill-fitting shoes, as well as unconventional triggers that cause infection. They present late to traditional healers, and this delays hospital admissions, or they go to the pharmacist and pick up medications from there. It doesn't work like that. This also contributes to antimicrobial resistance, again, where we play a role. A single ulcer can cause years of the patient's life savings. This is particularly from Dr. Abbas. Dr. Abbas is a Tanzanian gentleman. He's a physician endocrinologist, completely dedicated his life to foot-related complications in diabetes in Africa. And he's done several studies. And a simple DFU can just cost about an international USD 102 to manage. But if it's a complicated DFU, it goes up to 3,060 per month. That's a phenomenally high cost. It's when the system fails that the amputation is what results in the amputation. So treating an end-stage diabetic complication drains tertiary hospital resources as well. It requires intensive care, extensive radiology, and prolonged costs. Yes, we pay for SHA. SHA pays for certain patients, but imagine the economy drain. On top of that, this is the working class. So how are we going to manage all of this? This is also from a study done in South Africa. Unfortunately, we don't have great statistics and data from the Kenyan context. There's only one paper of the economic burden of diabetes, and that did not focus much on the foot complications. But you can see an equivalent of 2 full years of an average income, annual income, is what it costs. This is how much a lower limb amputation may cost, right? And a foot amputation. There's definitely a difference. So what is the solution? Are we to become more proactive at the point of care, at where each and every one of us are at? Where I'm sitting in diabetes foot clinic, am I supposed to look at only foot and wound ulcers? Am I supposed to see every person living with diabetes and supposed to screen them and educate them? Yes, that's all of our roles, right? Most of us deal with individuals living with diabetes, so each and one of us have a role to play at point of care. We have to decentralize that, and we have to make sure that it's nurse-led, or until we get enough podiatrists on board, we should be able to make sure that it is nurse-centric or even physician-centric, wherein we're able to screen, educate the patient, and help out with that. This is just a general intervention to reduce the burden of diabetes and diabetes foot-related complications, moving the care from hospital to community. It's helpful to get decentralized a little bit. That goes with us. We don't have to wait for everything to come from higher up and referrals. It doesn't work like it does in the NHS. It just doesn't. We want to take examples from certain centers, certain countries. It doesn't work in our setting because our setting is completely different. So this is what you can do. You can ask your patients to do daily visual checks. You give them footwear education. It isn't that difficult. If Doc looks at my foot right now and my footwear right now, his inclination is to try to bend it like this to see if it works. How many of you have seen him do that? Well, you guys have, but what about you guys? You guys have too. But it's important to talk about good footwear. You don't just say sports shoes. You talk about sports shoes with good outer sole support. Talk about good sports shoes with ventilation. They will speak about themselves. And of course, you tell them for early presentation. Any cracks, cuts, heels, you must come to the doctor very soon. You don't wait for things to happen. You don't wait for a catastrophe to happen, for the cost to go up. In before that itself, with primary care, you should be able to manage. Let's go into the cases. Are you able to see these cases? I'm not able to see over here, so I'm going to look at my laptop. Please forgive me. So this is, again, I will not go through this. How many of you have heard of the Wi-Fi screening? Wi-Fi classification of wounds. Wound, infection, ischemia. Please look this up. I will not go through this, and if you want to talk about it or want resources, you can come and talk to us about it later. But Wi-Fi classification is very important to understand. There are many classifications out there, but Wi-Fi is what is being used by the IWGDF, International Working Group of Diabetes Foot. So just like we follow ADA guidelines and NHS guidelines and NICE guidelines for diabetes, there are diabetes foot-related guidelines that I encourage all of you to follow. They're very simple to use, and you can always reach out to us if you need a further interpretation of the same. Let me talk about case 1, where I find that time is very important. This was a delayed referral. This gentleman came to us living with type 2 diabetes, systemic hypertension. He walked into the clinic. He wasn't even in my office. He walked into the clinic premise. And I'm like, a smoker has come. How many of us smoke? Man, I thought automatically a few hands will go up. Good boys and girls. So this gentleman was a smoker. He walked into the clinic, not even into my office, and I smelled. And I walked out of my office and I looked at him and I said, I'm judging you. He said, Daktari. I'm like, yeah, I can smell you from a mile away. You're smoking. And my question to them is always, do you have extra money? So you give me, I give it for another patient's health and well-being. He just looked at me like, you're crazy. He had a history of trauma about 8 to 10 months ago. And the ulcer was present for the past 5 months. This is how he presented to me, and his HbA1c was 8.2. His renal function was good. He was trying his best to take his medication, but of course he was not on good medication. He was only on sulfonylurea and metformin. I managed to do my physician part of it and everything. But as a physician, it's not just metabolic control and infectious control. I should know where this person must go next. So at the start itself, I had started priming him that you need a CT angiogram, right? He refused in the beginning. After a couple of weeks, and he said, no, Daktari, please dress for me. Now I can't turn him away, so I dressed for him. At every visit, I have documented that I have advised CT angiogram. When the CT angiogram came in, there was a full extensive vascular occlusion. Then finally, he listened to go to the surgeon, and he had to go to the vascular surgeon. The vascular surgeon said this is not going to help, but at that point in time, it was this bad. So yes, he did need a surgical debridement. He had systemic antibiotics, underwent glycemic optimization. But you know what? He came too late. Time is tissue. It's very important to understand that vascular assessment was done right at the beginning. I could not feel any pedal pulses, so I was very sure that he has vascular compromise. But despite of me advising him, he did not go for his vascular assessment, did not get revascularized on time, and this is where the problem lies. He underwent a major transtibial amputation, and we are still in touch with this gentleman, but yeah, he's upset. He's quite distraught that he lost his foot, of course. So that was about a delayed referral, neuroischemic DFU with a major amputation. Here we have case 2. This is an 84-year-old gentleman. He speaks Kimeru. He comes to me and he goes, Nikoega, and I have to say, Voego mono. I don't know if my pronunciation is correct, but he will not get onto my bed before he hears a proper greeting from me. And that's proper for him, so I'm happy. This gentleman is an 84-year-old gentleman, sorry. Yes, this gentleman is an 84-year-old gentleman. Remember, just because they have diabetes that is in the system, do not rule out venous ulcers. This gentleman has refused to undergo any kind of surgical intervention. I think Dr. Samir will advise whether grafting is necessary. In fact, he has seen this patient, and he has advised for a graft in this patient because vascularity is good. He's biopsy negative. He's lived with this ulcer for the past 4 years. It shrinks, it increases in size. The periwound skin breaks down sometimes when it's hot, when the cold weather comes in. it makes a big difference. But again, do not forget that it can also be a venous ulcer. So don't forget compression. This Guka refuses compression. He does not wear his compression stockings. So that's where the challenge is. But we continue to treat and we advise um, dressings and we have advised grafting. Case 3 is a recurrent diabetes foot ulcer in CKD. Individuals living with chronic kidney disease, even if it is stage 2 or stage 3, it's extremely important for us to pick up on foot-related problems and complications. How many of us work in a center where there's like a dialysis happening? How many of us work in a center of dialysis? There you go. I would encourage each and every one of you, and even teach your nurses, please do foot assessments while these patients are undergoing dialysis. It will make a big difference. I was actually talking to Dr. Fabian and team as well, that this is where podiatry chairs can be put up, partially. As the individuals are undergoing dialysis, their feet, their nails, everything needs to be looked at, and this is where you can educate them for diabetes foot as well. It's a good catchment area for you guys. It's great screening for you guys. It takes literally 3 minutes. Look up the 3-minute foot examination from ADA, and you will find that it does not take a long time at all. And it doesn't have to happen at every visit. You see the patient every time. There's Dr. Richard. He taught me one thing, taught me many things. This is the one thing that has stuck very well. If you look long enough at your feet, even if there's an extra mole or a hyperpigmentation or a crack, you will pick it up. So teach your patients to familiarize themselves with their feet. It is wonderful advice, and I still use it up to date. So in this patient, he had a DFU in 2025. He healed, and then he recurred this year for me. I just wanted to remind you that it's very important for you to also tell persons living with diabetes, if you've had a diabetic foot ulcer once, it's not going to go away. Recurrent episodes do happen, so make sure that you come immediately you find any chance of any signs of the wound opening up. Then we had this gentleman coming in with wet gangrene. He's living with type 2 diabetes from 2005. He had a thorn prick injury, and he had a previous graft failure. Okay, right underneath the foot over here, as you can see. Adjunctive therapy. So the most important therapy that my colleague Kennedy will take you through is sharp debridement. But it's very important for you to also understand that adjunctive therapy helps and can actually be economically very feasible to do proper sharp debridement and consider adjunct therapy. When we say adjunct therapy, we talk about, yes, the wound dressings, which Kennedy will talk about, but I'm also talking about things like topical oxygen therapy. While it looks like the cost burden goes up immediately, in the long term, I don't think I have much time to go through my health economics, but in the long term, doing adjunctive or adding on adjunct therapy, it improves quality of life and reduces the days for wound dressing as well, and improves the daily activities of living. If you know about DALI and QALY indexes, this is what I wanted to talk about. And here is another limb that healed despite every obstacle. This lady came to us from Nakuru in 2023. She's been living with diabetes since 2016. Rapidly progressive neuroischemic ulcer. For this lady, she came in, she agreed for vascular intervention, underwent vascular intervention, but had pain sensitivity. How many of us have used larva debridement therapy or maggots in their practice? Like actively put them in? I have. I call them my angels. How many of you run away from the maggots? I don't like intrinsic maggots, but we introduce maggots into wounds. Caldro have a beautiful program. Whenever you have a patient who requires debridement, cannot afford it, is pain sensitive, sharp debridement may not be an option. These are the indications that I know of, and I usually use maggot debridement therapy. We use them in biobags so they don't go all over the place, but they do a fantastic job in cleaning up the wound bed. And this lady healed. She lost only one toe, which was an auto amputation. This one Kennedy and I also managed, and Dr. Fabian was there at this point in time. But she underwent everything. She walked into my clinic just 2 days ago, and she said, Daktari, I have another wound. But luckily, it's a very small wound, but it's because of the recurrent diabetes education, we were able to get her to come much, much sooner. And we did topical oxygen therapy for her as well. Topical oxygen therapy is not the same as hyperbaric oxygen therapy. Please note. A quick note about the economic case of diabetes. I'm sorry, I had to cut this graphic down. It was one whole graphic and you would not have been able to see anything. So we did a few we did a few calculations. I'm making use of labor. I have an intern who's from finance department and I have a girl who has finished the statistics and data analysis. I put their brothers and sisters. So I put them on the task. I gave them my diabetes foot numbers. I gave them numbers for um, diabetes foot ulcers and the costs that they have incurred at our clinic, as well as individuals who are not living with diabetes foot. And the number is staggering, and also regarding adjunct therapy, et cetera, et cetera. The cost of a single amputation came up to approximately $21,441 when it comes to the prices at our clinic and basically basic referral hospitals. The major cost drivers were ICU stays, general ward costs, employee compensation, and extensive radiology services. And they had the lowest quality of daily living. As you can see, lowest quality outcome on the far left. And on the right-hand side of this image, you'll see the solution, success of limb salvage. When you're able to use adjunct therapy to preserve this limb or salvage this limb, the outcomes are much better. There's a lot of cost savings with interventions. Yes, you will invest a little bit right now in oxygen therapy, maggot debridement therapy. It might seem like a lot, but in the long term, their quality of life and it's an overall win situation right there. It improves things a lot, not on an individual basis, but also on a societal basis as well. This is something similar, saying that although adjunct therapy can sometimes be an extra cost and might be a burden, but if you're able to tell your patients that this is going to do better for them in the long term, they're sure to listen, they're sure to actually follow through. I will again not go through this, my time is up and we started a little late, but you can always ask us questions about this. But conservative wound management can cost actually 20 to 40 sessions, while complex limb salvage plus adjunct therapy can do more, and major amputation costs much more. So it's all about informing your patient. Remember, the patients of before are not what you're treating right now. There's a lot of information out there. There are a lot of people who may not have the best interest in mind for the patient, but only for themselves as professionals. So it's very important to understand and give them the information and allow them to make a decision for themselves. Yes, I can spend this money right now so that my limb is salvaged, or no, I cannot spend this money now and I can possibly undergo an amputation wherein my quality of life and my longevity is also impaired. Time is tissue, vascular status determines healing potential significantly. Healing is not the endpoint. Prevention of recurrence is endpoint. This is where podiatry comes in as well in a huge manner. If an individual has undergone an amputation, the biomechanics of the foot take a hit, and Dr. Hafsa will take you through it beautifully. Offloading is such an important aspect. Again, it costs money, but it prevents recurrence of wound ulcers. Sequential adjunctive escalation works. Just like clinical inertia in diabetes, where we shy away from starting insulin, for example, or starting a new therapy like a GLP-1. Clinical inertia can be from both your side as well as the patient side, but it's very important for you to understand you owe the information to the patient and they're to make the decision. So if you don't know about these therapies, please read up on them and we're available. And prevention of amputation funds many interventions. If I prevent one limb amputation, that same money from the SHA can go for everything else. And with that, I'd like to conclude. Thank you. I'd like to hand over to Dr. Hafsa now. No, sorry. It's to to Kennedy right now. So you'll switch over the presentation. They have daggers for a reason. Here you go, Kennedy. Thank you.
Thank
Here
you.
you go. It works.
Good afternoon, everyone. I'm not a preacher, but I can try. You're comfortable from find your topic, you're well visible and such. I know I'm black. I look like a shortcut to get to the other side. Okay, my name is Kennedy Omondi, wound science tissue viability specialist. I know it's after lunch, and one of the worst people to sit around when you're having a meal is Dr. Shilpa, because she'll be always talking about this chicken looks macerated, like if you know what it means when in wound care, some status can be able to point out. One of them is maceration, and she likes it a lot in chicken. She loves soup. Okay, so in this session, we are going to talk about precision. And remember, this comes about on how we're going to prevent chronicity in wounds. How do we make wounds acute instead of chronic so that they progress on to heal as expected? I'm very sure all of us have managed to wound at some point, or you've seen wounds, or you've had a wound, you know how painful it is. That's the same thing a patient is going through. We want the healing time to be as short as possible. So it's a bit interesting for you to understand how a wound heals. It's better to take note of that cellular interaction with itself, like what happens in the cellular level. We all see a big wound, necrosis, we see a lot of slough, we see like a maceration and so forth, but what happens in the cellular level? So it will be ideal to take note of how does the cell interact with adjacent tissues, uh, what are the disrupted functions. For instance, a patient who is diabetic but has got burns, like neuropathic, burnt his or her feet without knowing. Remember, the cellular structure, the cellular functions have been compromised. How will that wound proceed on to heal? So we need to know the disrupted functions of the cell and how to improve this cellular function or to replace these tissues so that they can proceed on to close. And how does the repair process occur at cellular levels? That is very important. So we all know these compromises. Wounds may occur in 4 different ways. I know you know of a list, but all those 4 lists fall under this: either burns, trauma, predisposing comorbids, and pressure, counter pressure, for instance, in like decapitated ulcers. And the management is different and according to the etiology. Though the healing process, the science of wound healing remains the same, like everything not viable has to be taken out. You need to take care of infection and inflammation. You need to balance on the moisture. How is the epidermal advancement and how is the surrounding skin? So those are among the key things we normally check for during advanced wound care to ensure that a wound can be able to, the process of the phase of wound healing continues as possible. It's also key to take note that sometimes wounds tend to misbehave, not because you're doing the wrong thing, but patient factors. There are intrinsic factors, which this is the patient factor, and at times extrinsic. These are elements which are happening outside. For instance, even our practice. Remember, our practice can also make a wound turn chronic. So it's good to take note that even our practice, the kind of environment, the kind of dressing materials that are using are going to make a conducive environment to ensure wounds heal. Multidisciplinary approach, very key. A patient, the patient's ID does not have your name as well. So this patient comes to you, you may not holistically be able to review this patient. You need to incorporate the podiatrist and endocrinologist, nutritionist. Them coming on board makes it easier to make the environment conducive for healing. So there are normally guidelines which help us come up with an appropriate management plan, and we call them principles of wound management. Appropriate history taking, you need to know more about the patient, more about the wound, so that it makes it easier for you to know how do we go forward from here. Remember, some of the etiology, some of the causes originate from the history. For instance, a patient diabetic, hypertensive, any other underlying factors, those ones you can only pick them if you get an appropriate history. History of even lifestyle. You do a very good job, but this guy, let's say, is a smoker, or I'm not condemning the smokers in the building, then we need to get note that if we can be able to pick this one, it becomes way easier. Then wound assessment using appropriate tools. We've all seen several tools in the market. Pick the best that will be able to combat both patient factors and the wound factors. It becomes way easier to manage this patient. I'll show you what my preference is. Then after getting now the history and you know how you've done an appropriate assessment, then you can be able to come up with a management plan. So together now, we need to also, now these are the principles we just talked about. Then we have a tool, an assessment tool. We know what we call wound bed preparation. By the time I talk about wound bed preparation, think about a wound with the three parts. That is the wound base, the wound edge, the peri-wound skin. If you just isolate and look at the wound on its own, you will miss on at the edges advancing. Remember, wounds heal from the edges. If you miss out the edge, you'll for a long time stay in one part without the wound progressing on further. So this wound bed preparation helps us do one thing: identify the barriers of healing. Remember, most of the times a patient comes to you, you just patch up the wound, you clean up, cover. The objective of this patient coming to you should be the other way around. What will prevent this wound from healing? If you can be able to identify that will prevent the wound from healing, you can easily take it out. And this is biased to granulation and epidermal advancement. If you don't have those two things, everything else is a compromise. So we need to find out what are these barriers that are going to prevent this wound from healing, take them out, that wound automatically progress on to heal. So the tool I'm talking about, I'm very sure we're all familiar with the acronym TIMES. They added an S recently. TIMES, that's the tissue, infection, inflammation, moisture balance, epidermal advancement, and then surrounding skin. That's about the patient factors. Think about a triangle of wound assessment as a holistic approach whereby we have that person at the back. So patient factors, how is the host? Is the host in a better status to take care or to ensure the wound is healing? So underlying conditions like glycemic control and so forth, nutritional status, pain and well-being. Remember consistency when it's coming to wound management. If a patient came to you and felt pain, most likely they might fail coming again. So are you taking care of pain as well and so forth? Then after you've taken care of the patient, then we're looking at this triangle. This is the wound bed. How is our wound base? How is our peri-wound skin? How is our wound edge? Are they in a proper position to ensure that our tissue is progressing on to close? There are several other tools in the market, but just an appropriate one for you, holistically combat the patient. So this is what I'm talking about when talking about the wound bed, the three parts. Our base, I don't know where, okay. Our wound base, our wound edge, or the surrounding skin. And we have several ways in which you can be able to give a description. I'm very sure most of us, you see a wound, like you tell to describe a wound, say the wound is clean, the wound is dirty. Those are not the terminologies required or to give me a mental picture of the status of how a wound looks like. We have a long list and there are more. Granulation, hypergranulation, epithelialization, necrosis, slough, desiccation, maceration, and so forth. It's a whole list. So how can we put this to practice? For instance, that list, I'm just going to give an example. When doing this description, we normally divide it into three. We have the etiology, the wound impression, and the wound bed parameters or the status. We can have it, for instance, in this example, like Mr. X, he's neuropathic with a calcaneus decubitus ulcer in diabetes. Assessment, we have a grade 3. So, for instance, you're using the Wagner's classification, the measurements, and then the wound base superior necrosis 60%, 20%, granulation tissue, and you can be able to see all the other parameters. So, from an appropriate description, if you give me such kind of a description, I can be in a position to pick out objectives. Mr. X, the patient is diabetic. I can be able to pick, okay, we need glycemic controls, we need things like biomechanics and so forth. He has got a pressure ulcer. How do we go about managing a pressure ulcer? The wound depth, because we know the wound has got a depth, can be able to see almost a 2 centimeter depth. What are the gold standards in managing deep wounds? And then there is necrosis and slough management, exudate management and infection care, like how do we enhance appropriate edges? How do we make the edges start advancing? And then peri-wound skin care. That is also very important. Remember, if we don't take care of the peri-wound skin, that might be the next wound. So we're just focusing on the wound, it might extend to the rest of the wound. So this science, holistically, remember we said the wound has got, the body has got capability to heal the wound. We just need to make this environment conducive. And it's not just about materials. So there is a lot more to help with this. So check the critical wound markers. They dictate the status of the wound. Make the environment conducive using appropriate methods, which we're going to look at. Talking about these dressing materials, there is a long list of materials. Those impregnated with antibiotics like foam dressings, hydrofibers, microfibers. You have collagen, maltodextrin powders and gels, debridement gels, a lot in the market, activated charcoal, paraffin gauzes, island dressing, we have films. It's a long list. But then there are more therapies which you can be able to add to make value or to make this wound heal quicker, like negative pressure wound therapy. That's a magical product. We use it a lot. Maggot therapy, Dr. Shilpa was mentioned. Transcutaneous oxygen therapy or topical oxygen administration as such. We have regenerative therapies like the growth factor concentrate, the protein-rich plasma, stem cells, very much presently done. Nanotech dressing materials. We have biomaterials engineered, for instance, like honey-based dressing, not the honey from Kitui. I remember when I was a student, during dressing time, you might think you're in a supermarket. Well, kuna Mumias sugar, someone got asali from Kitui, and so forth. Like we need to get the appropriate way of going forward with this one. There is sterile material, like a honey-based sterile material, which can be able to do the same thing, but without introducing, they're normally bacteriostatic. They just prevent re-entry of bacteria back to the wound after consuming the sugar. So there's an algorithm here, which I'm seeing I have some time. This algorithm is important, and we're going to categorize most wounds according to how we see them. I know, for instance, in diabetes, there are several stages, or there's different ways you can be able to categorize or group diabetic wounds, but this is very general. And this is biased to wounds or limbs with proper circulation. If there is no circulation, and if angioplasty is not an option, most of the times you normally consider conservative care, ensuring the wound remains dry, or at times, on the extreme, we have a region or a major limb amputation. But for such, let's say, prevention and protection of skin at risk of breaking, or you're having those superficial wounds, this skin is still intact. You don't have to do so much thick. Dressings simple as hydrocolloids can be able to ensure the skin integrity remains normal all through the time, like without breaking the integrity. Surgical sites, so in this algorithm, you can be able to see this is minimum exit level all the way to maximum, this a lot of, so minimum, moderate, heavily exuding wounds, and also infection status, like infection status can be able, if the patient is preventing systemic signs of infection, then to the maximum. So surgical site infections, someone has done an operation, there's minimum exudate and so forth. You can be able to see the base, even to the basic dressing materials available. Chlorhexidine, the paraffin gauzes, iodine sheets, so forth. They come in handy just to ensure, yes, there is no exudate. We can be able to protect these wounds from advancing, preventing infection as much. At the same time, if the infection or exit level increases, you can go all the way antimicrobial foam or negative pressure wound therapy, depending on the exit level. Prevention and protection of SSIs, we have debrided sites, maybe with grafts, flaps, or implants. Things like NPWT really come in handy to prevent such, to achieve like a tissue cohesion and so forth. Then ulcers less than 2 centimeters deep. This is where things change. I'm very sure most of us I've seen wounds packed with gauze. Like a patient has come to your clinic, there is a cavity, you put in gauze. So this is now biblical truth. Gauzes are not dressing materials. They don't have any medical benefit on the wound. So we use it to clean the wound, not to dress the wound with. So we avoid them. So they're appropriate dressing materials to when you're having depth. Things like hydrofibers, microfibers, uh, they help stimulate granulation, exudate absorption. You have a depth, they come in handy to help with that one. So tissue repair, so depending on the depth, if the wound is less than 2 centimeters, we normally do foams and other dressings, but to pack a wound, we use that category, alginates, hydrofibers, microfibers, and so forth. And depending also on the extent, we can be able to introduce negative pressure wound therapy, and that is after you've scrutinized the underlying wound base, and if there's possibility of maybe exposed structures and so forth. Yeah, I think I'm done. So in 20 seconds, it's good to take note that the science of wound healing is the same in all types of wound, like remove non-viable tissue, manage infection, manage moisture, the edge is appropriate, the peri-wound skin is ideal, then you can be able to appropriately heal that wound. Diabetic wounds and their complications are preventable, gold standard, and I'm very proud to say that one. And then management is based on assessment. Dr. Fabian here loves saying, listen to the wounds. What the wounds tell you to do is what you actually do. Makes you get like proper outcome. Wounds heal best when covered. Don't leave wounds open until the integrity of the skin has been restored. That is when we can now say, I'm going to expose these kind of wound. I've just talked about gauzes are not dressing materials. And then another gold standard multidisciplinary approach helps you to scrutinize extrinsic and intrinsic factors and make this wound heal appropriately. Then, especially those in remote setups, remember, early referral is as well treatment. The patient's ID does not have your name. To conclude, Dr. Shilpa was talking about the essence of time in wound care. I'm having 2 minutes so I can tell you a story. One of these days, get a frog or a toad, one of those ones. Which one lives, is an amphibian, lives on land and on water? The frog or the toad? The frog. Get a frog, if you can be able to get one. Put it in a sufuria. Add some water, put it on your burner or in a gas, then light it. I know at some point the frog will die. I'm not telling you to take the soup or to eat the frog, but just as a question, what killed the frog? Huh? And remember, the frog got one of the most powerful muscles to jump. It can be able to jump from this water if it feels the temperatures are high. What killed the frog? Huh? Suicide. It killed the moisture. Huh? The inability of it to know the right time to jump out of water. Huh? If it jumped out the right time, it will have survived. But because it can be able to adjust its internal environment to the surrounding heat, then at some point, it dies. It gets too hot for it. Think about it. Thank you so much. I'll end it. Yeah, thank you. I'll take the opportunity to welcome Dr. Hafsa. Thank you so much.
All right, good afternoon. So, ladies and gentlemen, if this patient came into your clinic today, what would you do? Anyone? Amputate. Let's hope not. All right, so can I use this? Ah, there you go. Ah, can I get rid of this? Thank you. All right. So can you hear me? All right, great. What is offloading? It is defined as any measure that is used to reduce overloading or excessive pressure on specific parts of the foot to allow healing or to stop recurrences of wounds. Pressure or load redistribution is not a complementary or an extra step in diabetic foot ulcer management. It is the cornerstone of every successful diabetic foot ulcer management treatment plan. My talk today is hopefully going to convince you all to start using offloading as part of your treatment plan for diabetic foot ulcers. Okay. Feet are the foundation of the human body. They are designed to support, absorb, and adapt. They are the masterpieces of engineering. Each foot contains 26 bones, 33 joints, and over 100 muscles, tendons, and ligaments. The foot is a complex structural platform designed for both stability and mobility. It is mobile enough to adapt to uneven surfaces, yet it is strong enough to carry the body's weight. Okay. Now, to get a better understanding of offloading the foot, we need to borrow some concepts from biomechanics and structural engineering. Structural engineers study the loading forces that affect structures such as buildings or bridges. They analyze these forces, and it allows them to determine what are the best materials to use for these structures to prevent any structural failure or collapse. We too can apply the same methodology to offloading the foot. What is a force, and what are the main loading forces acting on a foot? A force can be defined as a mechanical disturbance or load applied to an object which causes the object or to change shape. There are many different types of forces, but the three forces that I'm going to concentrate on are compression, for example, the body weight on the foot. Compressive forces squash the body, making it shorter and thicker. Then you have tension, for example, in the Achilles tendon or in the plantar fascia when you're standing still. Tensile forces stretch when under tension, making the object longer and thinner. And then you have shear forces. And an example of this would be the skin against the ground or the skin and the fat pad. Shear forces basically force parts of an object in opposite directions. Okay. Now, as a person stands, walks, or jumps, the ground pushes back on the foot. This force is called the ground reaction force. Now, I am going to talk a little bit about physics, so bear with me. But basically, the important principle here is Newton's third law of motion, which states for every action, for example, a body weight, there is an equal and opposite reaction, which is the ground reaction force. Now, this ground reaction force can be many times greater than the individual's body weight, depending on what the person is doing. So me standing here, the ground reaction force is exactly the same as my body weight. However, if I was to start running or jumping, the ground reaction force can be up to 3 times that of my body weight. Okay. Now, anytime a force is applied to an object, it forces the object to change shape. Now, the ability of the object to resist this force and resist changing its shape is called an internal resistance or its stress. This force is present in all materials, but in varying degrees of magnitude. Now, the amount of change in shape of that object under load is called its strain. Now, how is that relevant to us? Whether a structural tissue in the foot gets injured or not whilst under load is determined by its internal resistance or stress and the internal deformation or strain within these tissues. Okay. Now, the standard method used in biomechanics and engineering to describe this unique relationship between load applied and the corresponding change in the object is the stress-strain diagram. There are three main points on this diagram that are relevant to us. So specifically, this part, right? The origin is basically where there's no load and no change in that object. Then you have the linear region or the elastic region where the load applied is proportional to the amount of deformation in that material. Once the load is removed, the material returns to its original state. Then you have the plastic region. This is where the load increases past the elastic limit, and then you get deformation happening. Here, the material is permanently changed and will not return to its original shape once the load is removed. Now, in order to remain injury-free, the structural tissues of the foot must function at stress levels within this elastic region. However, if the tissues are loaded above their elastic limits, then plastic deformation occurs in the forms of ulceration and tissue loss. A clinician must consider the stress-strain characteristics of the various tissues in the foot when considering how that wound occurred and how best to reduce the forces acting on the injured tissue, which is essentially what offloading is. All right. This is the last slide on physics. Pressure is calculated by dividing the loading force by the total contact surface area. Therefore, in order to reduce the pressure, you have to increase the contact surface area. In other words, reducing the loading forces means you increase the surface area over which the body weight is distributed. Understanding each patient's unique foot profile, gait, and the loading forces is an essential part of offloading. Okay, so how does offloading work? It reduces the pressure of the loading forces and the shear forces at the site of ulceration. It reduces the motion of the joints in the foot, so reduces some of those compressive and tensile forces. And it decreases the time under load or the amount of time a patient spends weight bearing on the compromised foot. Okay. Our feet are loaded by our body weight for every step we take every day. For most people, this load is carried with no problems, no pain, no issues. Pain is our body's early warning signal to respond to overloading. It encourages us to naturally offload the area by limping, changing your shoes, using crutches, or even using a walking stick. With diabetes, however, you have the critical triad, which increases your risk of diabetic foot ulcers and tissue loss. You have neuropathy, where you have no pain signals to limit overloading. You have diabetic foot changes, which results in altered biomechanics, which concentrates forces into dangerous high-pressure zones. And you have continued microtrauma, which on an insensate foot converts minor injuries into chronic, non-healing ulcers. Okay. So some of the important diabetic foot changes include small muscle atrophy, which causes muscle weakness and deformities and can also lead to increased plantar pressures. You have motor impairment, so Achilles tendon shortening, damage or rupture to the plantar fascia, and all these things can cause what we call an equinus deformity. This is where most of the body weight sits in the front of the foot. Or if you're a woman and you're wearing high heels, all your body weight is in front of your foot. And of course, you have biochemical changes in the soft tissue and joints, which causes stiffness or arthritis, which affects both the stability and mobility of the foot. Okay. Now this slide shows how some of these diabetes-related changes and comorbidities manifest in the skin, which can further deteriorate, resulting in ulceration and tissue loss. Now, especially important is the ischemia and the peripheral arterial disease, because it is something we need to consider when talking about wound management and offloading. So some factors that affect the normal biomechanics in a diabetic foot. course, you have deformities. So for example, clawed toes, amputations, or a Charcot foot, abnormal gait caused by neuropathy and uneven loading, limited joint mobility and repeated plantar pressure shear stress, which all contribute to high-risk areas on the diabetic foot. So here are some of those areas. So you're looking at the plantar forefoot, so underneath the metatarsal heads, under any bony prominences, for example, around bunions, the collapsed midfoot in a Charcot foot, under the tips of the toes, especially when you have the clawed toes, the dorsal surfaces of the IPJs if the person's wearing inappropriate shoes, and under the heel. All these surfaces are prone to ulceration due to increased pressure and reduced contact surface areas. Okay, here's the pie concept of healing. Wound management is a multi-factor effort. However, without effective offloading, every other intervention is undermined. Each component is important, and it can be likened to a filling and crust of a pie. You can't make a pie without a filling or a crust. Then it's just simply a biscuit. But so you have glycemic control, nutrition, infection control, vascular supply, and debridement are the filling and the crust. Offloading is the pan that holds everything together. All right. Now, the first step of offloading is the removal of all hyperkeratotic or thickened skin and or non-viable dead tissue. Remember, the skin should feel like a chapati, not a biscuit and not a piece of bread. Okay. Offloading interventions are based on the guidelines developed by the IWGDF. So when choosing an offloading strategy, clinicians should follow a stepwise approach. Start with the most effective option that is appropriate for your patient and step down only when necessary. For plantar ulcers with 0 to mild ischemia and or 0 to mild infection, the simplest option would be supportive shoes combined with some internal padding and cushioning. For bigger ulcers with moderate to severe ischemia and or moderate to severe infection, you could look at removable knee-high or ankle-high boots. Now, the gold standard is using total contact casts or equivalent. However, this step is not always accessible or advisable as it requires expertise application, regular monitoring, and is only suitable for specific wounds. Patients tend not to like total contact casts because they are non-removable and can become uncomfortable and decrease the quality of life. Now, total contact casts, they are considered the most effective intervention. They are the evidence-based first line of defense against increased plantar pressures. They work because they increase the weight-bearing surface area, which effectively reduces the pressure. And they are more effective than other interventions because they have the compliance advantage. Patients can't remove them, so they work 24/7. Now, here are some more examples of offloading interventions that we use. I actually have a few on the table in front, so afterwards, if you have time, come and have a look. Here is an example of one of our success stories. The amputation site was successfully healed using effective offloading as well as wound management. We started off with direct offloading, so it was a felt pad directly onto the foot, and the patient was completely non-weight bearing, so he was using a wheelchair. As the wound healed, the padding was removed from the foot and put into the shoes, and weight bearing was gradually reintroduced. However, there are some cases where conservative measures fail. This is where we consider the surgical interventions, which Dr. Samir will cover. Approximately 30% of patients with diabetic foot ulcers will eventually require surgical intervention. Now, the cost of inaction. Lower limb amputations due to foot ulcers are the third most costly diabetic complication. A single untreated ulcer increases the risk of a second ulcer developing by 77 times. Between 5 and 24% of patients with DFUs end up with a lower limb amputation due to failed or inadequate offloading. Failure to offload drives the vicious cycle of recurrence and amputations. It is early, aggressive intervention that is the proven way to break this cycle. All right. Now, offloading is an ongoing management intervention. It must be continued even after the ulcer heals because the original factors that cause the ulcer are still present. The foot shape is still altered, the loading forces are still there, the diabetic foot changes are still there. Continued success depends on education, consistency, and access to a multidisciplinary team. Patients must understand why offloading matters even once the ulcer is healed. They need to be aware that therapeutic footwear is a lifelong commitment. It's not a temporary measure. And finally, access to a multidisciplinary team has been shown to reduce the incidence of recurrence. So, in conclusion, healing isn't about what you put on the ulcer, it's about what you take off. So again, I have this picture of this person that I showed you right at the beginning. What you need to do is identify the pressure points, the loading forces that are driving that tissue breakdown, apply the right offloading intervention, and commit to offloading. It can save a foot. Thank you. All right, and now I'd like to call up our pod surgeon, Dr. Samer.
Can everybody hear me okay if I just talk like this? Perfect. Let's go. Okay, so how many, just from a show of hands? All right. With a show of hands, how many nurses do I have here? 0 nurses. 1 nurse, 2 nurses. How many physicians? How many surgeons? Okay. How many people have dealt with a diabetic foot? There's some people who haven't put their hands up. All right, so we'll do some learning here. Everything that everyone's talked about is very, very relevant. And when things get to a certain point, that's when surgery comes into play. For today's little lecture, what I want everyone to sort of wrap their heads around is how to think like a surgeon, okay? All of us, for all intents, I want you to maintain that mindset of what does a surgeon think like, so we can figure out what to do, when to refer, how to talk to our people in our interdisciplinary team. So a few different things I want to go over. 1, the surgeon's mindset, so how we think. 2, the biomechanics, not just from an offloading standpoint, because as good as it is, it sometimes does fail, and we have to look at surgical biomechanics. The surgical toolkit, and contrary to popular belief, amputations are not the only thing that we do as surgeons. Charcot, often overlooked, I want to go over that. Amputations done correctly, the surgical decision sequence, and then finally, what does that mean for us who live in Kenya? So the mindset. We don't just cut, we rebuild. Unfortunately, in surgery, there's this mindset that when we come to the surgeon, we're looking for a finite solution. They come to us, you fix it, bring it back when they're back tomorrow. Okay? That's an ablative way of thinking. When we come to the surgeon, and you're all surgeons right now, we're going to go through a reconstructive mindset. Our idea is to rebuild this foot. Not for today, not for tomorrow, but for many years from now. So with the ablative mindset, the idea is to remove the problem. Chop it off. All done. We want the shortest possible operation because we don't want to deal with it anymore. It's already failed everything else. We ignore the tendon, we ignore the biomechanics, we just want to get it finished. We want to close it right away. Any flap, any closure, that's what works. And unfortunately, when we take that approach, we have a very high reamputation rate and very poor long-term outcomes. Not ideal. Remember, we're thinking ideally, we want a reconstructive mindset. That means creating the best tissue will work? What's going to work in the future? How are we going to plan our soft tissue? Not just our bones, not just our tendons, not just our closure, all of it. You want to address the biomechanics at surgery. You want to think about it beforehand. You want to address it afterwards. You want to think on the tissue so that we get that low reamputation rate and a great long-term. So when we have a patient, and this comes as soon as they walk into your office, it's what do we need right now? Controlling the infection, removing the dead tissue, closing the wound, maybe less obvious, but oftentimes something that we think of right away. And that's fine. That way of thinking is appropriate. Where we often miss the mark, and we've all done it, I'm sure some point in time, if we forget that question, what will this look like in X number of months? 1 month, 3 months, 6 months, a year. What are we trying to achieve? And then beyond that, what's going to be the most durable result for the patient life? As a diabetically salvaged person, I like to think we try to save everything. But there's some situations where we decide to go through a full amputation unless it's the right decision. And figuring out what works for that person long term becomes very important, and we want to bring it into our way of thinking. So let's go into the biomechanics. Most people, unfortunately, when we talk about the foot and ankle, we skip over what the different tendons do and what kind of forces they have. So this is a little overview on what does what and what's the result. I won't go on into too much detail, but at the very bottom you sort of see a little thing that I try to tell people is every unopposed force is where the next also force. So recognizing what forces are being put on the foot and where the pressure is being borne helps us determine what procedures we need to do, what offloading mechanisms we need to look at, and what to tell the people we're referring to what this patient's situation is like. So the biggest one, and I'm going to leave this one like a dead horse throughout the talk, is the Achilles of the gastro. We all know, and if you didn't know, now you know, incline flexor disc pain. Now, that significant amount of pressure through that equinus deformity puts so much force onto the forefoot that we tend to have recurrent ulcers. This gets missed over and over again. We're going to talk about different types of amputation. Just because we lop off the front of the foot doesn't mean we become recurrent. The tibial anterior, the tibial posterior, great inverters of the foot. If they're left unopposed, you get, unfortunately, significant amount of breakdown elsewhere. The patient that's on that left-hand side, unfortunately, I've seen with Dr. Silva, had gone through, for better or for worse, in this case it turned out to be worse, had an ulcer, and correct me if I'm wrong, was on the lateral aspect of the foot. The mindset at that time, and I can't say for certain because I've never actually talked to the surgeon who's done it, but the mindset at that time was likely, we need to get rid of this ulcer, what can we do? And my guess is there was probably some degree of osteomyelitis or bone infection at that metatarsal base. Now the decision that was made at some point in time is we're going to debride this ulcer, we're going to fix it, and we're going to get rid of that osteomyelitis. Fair. Unfortunately, getting rid of that osteomyelitis, they resected the fifth metatarsal. When you resect the fifth metatarsal, you get rid of that peroneus brevis happens. And what happens? Now this patient is walking on the dorsum of their foot. Now, unfortunately for this patient, that's not a reconstructible foot for her, given her resources, given her ability, or what she needs to do on a day-to-day basis. And I can see she still has this foot, yeah? She's still walking on the dorsum of her foot, not very functional. Now, for example, this is a type of patient where you decide what's best for the long-term lifespan of the patient. She's actually quite young. She would be in a good category to actually consider a below the amputation because she has the ability to rehabilitate it, she has the ability to fit into a good prosthetic, and that might be an option that's good for her. So recognizing what forces are being unopposed will help us determine what we need to do. Different deformities are also going to give us that little insight on where we can expect alteration. Dr. Hudson talked about it. When we're looking for clot those ribs, we saw in our little diagram where those threads clot, we're going to get pressure on the dorsum of the toe. When we have someone with a bunion or a halocephalic rib, we're going to have some irritation probably the second metatarsal, the medial axis, the third metatarsal head. If we have someone with a completely flat arch, whether it's a really flat foot or a sharp neuromuscular arthropathy, you're gonna expect an alteration in that midfoot, in that rocker body. That tight Achilles, again, super important. Don't miss this one. If you don't miss anything, that's what I want you to pay attention to. That's just putting increased pressures to the forefoot. So all of those need to be addressed, or at least recognized, whether you're a nurse, physician, surgeon, endocrinologist. That becomes very, very important. You don't need to be a surgeon to recognize it. Understanding the basic biomechanics of the foot, and sometimes that just means going to a textbook, rereading what those major things do in the foot. You'll understand where those alterations are likely to occur. And we can coach our patients from the Achilles tendon. This is our biggest adversary. This is what we're fighting against with majority of the time. It's the most powerful tendon in the body. Like Dr. Hussa said, 3 times our body weight when you're pushing off, it can be low. So when you're putting that kind of load on the forefoot, that's something that you need to address when looking at the thing surgically or conservatively. Now, how many people have heard here of the silver skull maneuver? 0 people. Not even your podiatrist. So this is a test where if you're seeing a diabetic foot and you are assessing a diabetic foot, I want you to do this maneuver because it takes about 10 seconds. And it will significantly help the conversation going forward with any other specialist you're talking to. All I want you to do is dorsally flex the foot. Stick your thumb on the 4th and 5th metatarsal head with the patient's foot extended and the knee straight, and push up to see how much dorsiflexion you get at the ankle. You should be able to get between 8 and 10 degrees of dorsiflexion. As soon as you've assessed that, let them bend their knee. See how much more dorsiflexion you get. The reason this becomes important is one of the biggest things we need to address to our patients is how to manage that quantity. Whether it's through simple stretching, whether it's through cutting their Achilles tendon, whether it's through releasing their gastroc. And what this differentiates is what's coming from the gastroc and what's coming from their shoulders. If you can get 8 to 10 degrees of dorsiflexion when you bring up your foot, awesome. No appliance. Don't need to do anything. If you can't get that 8 to 10 degrees of dorsiflexion, and all of a sudden you bend their knee, you get that motion, then they have gastroc appliance. So all their tightness is coming from their gastric ligaments. That means if we have to manage that, whether stretching, we coach on stretching that muscle. If we're cutting the gastroc. We're not cutting the Achilles tendon. If they bend their knee in, you still can't get that ankle to move. That's where we have gastroc shoulder appliance. Okay, that's when we're addressing the Achilles tendon. Very, very important. And I have a couple of pseudo case studies at the end to go over. I just want you to keep that in mind. This goes back to, again, what happens when we don't think about the biomechanics. Now, this is more so after we've done some sort of respective surgical intervention. So, if anyone wants to slide more than happy to do. The one that I'll sort of get you to really focus on is that one in the middle, the TMA without the Achilles tendon. Transmetatarsal amputation is one of the best amputations we have. Very functional, we'll talk about that. But if we don't address that equinus, it can be, unfortunately, a failure. Still part of the strength amputation, for whatever reason, I've seen more of them here in Kenya than other places in the world. Very, very high failure rate. Why? Because we don't tendon balance, because it's a difficult thing to do for many surgeons who aren't trained in the clinical space. And so, it's better off to avoid that amputation if you're not going to do that. And then, if you're independent, if you over lengthen it, it's a different set of complications. For example, that calcification, putting too much pressure on the field. It's important again, these are not random complications. This is when we rush through a surgical procedure, we don't think about the biomechanics, we end up with this situation. So the surgical toolkit. When people usually ask me, what do I do for this patient? It's how do we salvage this limb via amputation? Which is fine, it's an acceptable question. However, there's so many other procedures in the bag that we should be aware of, or we should have a conversation about. So I'll go over them briefly. There's minor procedures, so flexor tenotomy, the nail procedures, our little skin clasp, tendon procedures, lengthening the gap up sessions, the tendon balancing, very, very important. Osseous procedures or bony procedures that are not amputated. So isolated metatarsus hyperextension, conservative lopping off a piece of bone can be very helpful. Exosterectomy for massive charcoal feet that are in coalescence, they have that rock bottom foot. Sometimes just cleaning that off can be a very simple surgical procedure for a lot of general surgeons that can help the patient. And then skin cover. What kind of flaps, which type of bandage will you use? Now this one, how many people have dealt with an ulcer on the tip of the toe? No one else has seen one? Really, really common. Now, as you know, I think Dr. Carlos mentioned this as well, we don't have a lot of podiatrists in this country. There are 8 people. Not a lot of them, or many of them, do surgery. Even having a number of plastic surgery or orthopedic surgeries are limited in this country. I might get sort of flack from it, but this procedure, the percutaneous flexor tenotomy, I believe personally is a procedure that we could teach every one of you here in the right circumstances to do and save toe ulcers as a result. It's a procedure that takes about 2 minutes. We release the flexor tendon, so the tendon that does this to the toe, and you can go from a toe like this to a toe like this within a couple minutes. With flexible contractures of the toe that have ulcers at the tip, this is a better alternative than just lopping off the foot. So if someone has a quad toe or a bent toe and an ulcer at the tip of the toe, what I want you to try to do is see if you can straighten that toe. If you can straighten that toe, we talked about doing a tendon tenotomy. And that, at this stage, you'll be referred to someone who can do it, but hopefully at some point in time, we can teach you all how to do it and you can all get your cut on it. The Achilles tendon lengthening, also a very important procedure. This is to release the amount of flyness in the back. So remember we talked about that silver skull maneuver? If you find that both the gastroc and the scolium is tight, releasing the tendon, not cutting it completely, but lengthening it, takes the pressure off the forefoot. There are studies that show when you have a forefoot ulceration and you do Achilles tendon lengthening in someone with declinus, the recurrence rate goes down from like 84% to 22%. It's a significant reduction in the recurrence of forefoot ulceration just by addressing this Achilles tendon. If it's just the gastroc and not the Achilles tendon, we do something called a gastroc recession, we're just lengthening the gastroc. I personally love this procedure. It's a lot easier than I feel than the tendon Achilles lengthening. Still preserve good gait. The soleus is preserved, that's good push-up power. The capsule recovery comes very, very quickly, and you don't have that risk of rupturing the Achilles tendon and getting that calcaneal gait. And this, again, gives about 80 to 90% improvement in patients with forefoot ulcers. Balancing, like I talked about, is important. Again, the TMA, the transmetatarsal amputation, walking off the front of the foot, we talked about. If you don't do a gastroc or a TAL with that, in my mind, I'm sorry, that becomes a failure if you haven't talked about it. Because you've now turned a very functional amputation into something that's potentially less functional, and you may have to. is 99% non-surgical. It's when we get to the shit show at the end that we need to reconstruct, and we deal with that situation at that time. But in my mind, any one of you referring a patient to a specialist because they had a red, hot, swollen foot, and you said, I think this patient has Charcot, or you see a red, hot, swollen foot, you put them into an air cast because you think they may have Charcot and refer them, you will have a phone call with one of the specialists to say, I think this patient may have Charcot or a red, hot, and swollen foot. That to me is the pinnacle of diabetic limb salvage. You then are a salvager of the diabetic foot just with that recognition. So keep that in mind. When we get to that complex reconstruction phase, there's internal fixation, there's external fixation. These are very complicated procedures when we try to rebuild the foot. Unfortunately, we tend not to have the resources here in Kenya for a lot of that reconstruction to take place. So you want to prevent everything going forward, that going forward. Amputations. Okay, so amputations, this is important, and this is why everyone refers to us. Toe amputations, taking off the toes. It's probably the simplest amputation. With these guys, it's important just to preserve the primary skin and be aware of where things transfer. Transmetatarsal amputation, this is the workhorse. This is where most people who have some sort of forefoot ulceration or need a reconstruction should probably be going at some point in time. The reason this is so great is it brings patients to near normal ambulation. It's balanced. It's very predictable, assuming you treat the biomechanics, which, if you recall, Aquinas. If we can control that Aquinas and can make this a wonderful amputation, you can get people back to full functioning with this amputation. These are sort of just the overlying important sort of things to address when you're doing it. Good flap, good vascularity, good bony prep. But the last ones that are red for a reason, address the Aquinas. Remember the test to address the Aquinas? Anyone? The silver skull test. That's how we look at it. That's how we figure out what to address. This is why it fails. The one in the middle, it says Aquinas. That's probably the one that's most preventable of why these things fail, because that's not addressed appropriately. But obviously you want to check your vascularity, you want to check your flap, you want to make sure that they're well managed medically. You don't want them to wait there too early, and you don't want to be operating an effective field. This is not a definitive procedure all the time. Step one, treat the patient. Sometimes we need to stage this, and that becomes important. Please, again, if you're talking about these procedures with people in your circles, and they want to do a Livestrong or show part amputation, have the conversation of what are you going to do to the tendons, what will these tendons do to the patient. If you can't answer those questions effectively, don't do these amputations. You're better off if that situation is going on to a sinus amputation, so an ankle disarticulation or an amputation through the ankle, a below knee or an above knee. Now, obviously, those bottom two come with significant morbidity and mortality. Dr. Chopra talked about this. When you get to a above knee amputation, your mortality rate, and when your mortality rate goes up to 83%. So this is oftentimes a death sentence to our patients. So we only go to these when we have no other option. Limb salvage has failed in every other instance. This is not what limb salvage looks like. If you chop off the legs, if this is the patient that you have, and we hope for them to live a normal life, not in reality. I'll zip through this last bit because I don't find it as important right now, but this is a little bit of a framework. This doesn't exist in real life, so if you look up Dime's framework online, you won't find it anywhere. It's really just for this lecture. But the idea is to diagnose, so figure out what we're doing, deal with infected tissue, ischemic tissue, etc. Figure out what we want to do, manage the infection, map the forces. So again, look at the biomechanics of the foot. What are the tendons doing and why? Evaluate the vascularity. When do we get vascular involved? Early, right away, in the middle, and then have surgery with a plan. Figuring out again how we're managing the patient, not now, not in 3 months, but for the rest of their life. Every surgeon should go in, and you're all surgeons today, with the plan, I am going to see this patient again. Now, am I going to see this patient again, they're going to be happy? Or am I going to see this patient again because they've come in with the same or a different ulceration? This again, timing is everything, when to do what. We always want to drain, get rid of that infected tissue first. We wait until we figure out we have a viable tissue to work with before we do any sort of closure. We figure out what to do, level of amputation, what tendons we need to work with. Then we close it. Now we have that nice closed functional foot. And then we send it to Dr. Costa and Dr. Collis to protect that foot going forward. All right, how do we optimize this? Now, what does that mean for all of us here? We stick to what's feasible, but we know how to recognize what is not feasible. Flexor tenotomy is very feasible. Yale procedure is feasible. Achilles tendon lengthenings, gastric recession, narcolepsy is very feasible. Certain types of amputation, very feasible. Grafting, feasible. Exostectomy, feasible. You got plastics, all these plastic procedures are feasible. Where we need that reconstruction is we're dealing with Charcot, dealing with free flaps, dealing with complex hindfoot abnormalities. When we see these and they're out of our realm of understanding or our ability to manage, know when to refer. Referral is not failure. Referral is a step to diabetic limb salvage. So know when to send on and don't let the ego get in the way. Language matters. And I think everyone sort of mentioned this at some point in time. How we address our patients is important, especially around surgery. Surgery is one of those things where if you say the wrong thing to the wrong patient at the wrong time, oftentimes you never see them again until they absolutely need you. So reframing how we approach this thing. So instead of having a patient with an ulcer say, oof, you might have to cut your toe, or ouch, yeah, that doesn't look like it's very good. You talk about, hey, there might be a procedure we can look at that may save your toe. Or when someone comes in, we've all done it, I'm guilty of it too, when you walk into a room and like, oh shit, well sorry, that looks bad. And the patient all of a sudden has a negative outlook on what their looks like. When we talk about, hey, if we catch this early, there's something that we could do. If we're on the same team, there's ways we can offload this. If we address this together, we can get you back to walking on two legs. Your foot has Charcot. I scared everyone about Charcot. Someone succeeds on Charcot, you might lose this foot. You can tell people, yes, your foot has Charcot. Like most people in this room initially, you don't know what Charcot is. Explain what that is. Explain the necessity to offload. Explain the ability for the patient to take control of their own life becomes very important. If we have that right conversation, we make limb salvage that much more accessible. I also want people to take away maybe one or two things from the lectures with all of us. So hopefully, even before I said anything, you guys took something away from all the other lectures. But these are some ones that we can consider. Remember, mindset should be reconstructed, not ablative. We want to go after blindness and make sure we can treat that. Learn about flexor tenotomy. I'll teach you if you want me to. I'm happy to do it. Hot, swollen, red foot is Charcot until considered otherwise. Every amputation changes the biomechanics. I don't care what level it's at, it has to change. Manage it. That includes with a transmetatarsal amputation. Don't do a show parts of this wrong because we don't know how to balance it. Drain, then reconstruct. Language matters. And the best surgery is the one that prevents the next surgery. Okay? So, quick presentations. These are based on things I've seen, but these patients are not real patients, so if they look like anyone in this room, we usually do this. This is Mary, so she's a 58-year-old diabetic. She's been diabetic, oh no, sorry, not diabetic. She's a person living with diabetes. Language is important. So she's on oral medication right now. Her blood sugars aren't the best maintained, but she's a very sweet lady. She's a very compliant lady. She does everything that you can tell her. She comes with this third metatarsal head ulceration that's been there again. Now, the unique thing about this ulceration, it's not her first time, it's not her second time, it's her third time. She's come to see you for the last 1.5 years. You know her kids, you know her students. She becomes a regular, and she does everything she's supposed to. She offloads, she does her debridements, takes her medications, she's trying to work with her diet. She's a very good patient. We look at the ulcer, it's about 1.5 by 1.5. It doesn't go to bone, It's got that thick callus around it. Doesn't look infected. She has good pulses, a good ability to heal. She's insensate in the forefoot, so when you do your monofilament test, you can't feel her forefoot. But otherwise, there's no other major neurological disease. And when you do your silver skull maneuver, because we talked about it, because you're all going to do it, you find that when you try to dorsiflex your ankle, you can't get to that 8 to 10 degrees with her knee straight, nor her knee bent. So based on that, I'm going to call on someone if no one actually answers. What should we do for this patient? Anyone? Yell it out. A TAL. Anyone else? I didn't believe it. So yeah, a TAL. So this is the thing where we can do the best wound care. You could be sending this patient to Kennedy every week, and he's a mastermind. And he gets this thing healed every single time, and then every 6 months you're sending it back to Kennedy. Okay, that's a lot of time Kennedy. As nice of a guy as he is, this lady does not want to see him over and over and over again. So by doing something as simple as a TAL, because of that Aquinas, that ulcer all of a sudden heals. Now we go into the future, 6 weeks, she's fully healed after being non-weight bearing after her TAL. She has no ulceration. She gets to maybe 5-6 degrees of dorsiflexion as a result. And then for the next 18 months, she has no recurrence. Okay, so she is a much happier individual. That's a success story. And all that's changed is we address the biomechanics. Something that takes a 20-second or 10-second test to figure out. And this is what our foot would look like. So when you see an ulcer in the same spot that keeps on coming back, what has someone missed in terms of biomechanical assessment? If there is restricted dorsiflexion because you've actually evaluated it, awesome. Send it to the person who can do that procedure. Second one, this is James. He's a 63-year-old retired civil servant. He's been a person living with diabetes for 9 years, and his blood sugar is not well controlled, but he's working. As you can tell in the pictures, he only got 4 toes. He's already lost his second toe, and now he's coming with this ulcerated tip of the third toe ulceration. Now again, it doesn't look infected. It's not probing the bone. It's his vascular status is intact. He's insensate, so he can't quite feel it. But we have to understand then, why is that ulcer actually forming? Because I hopefully talked about, you guys remember, if you straighten that toe and you can get it straight, what procedure are we sort of thinking about? What could we do? Thank you. A tenotomy. You release that tendon, and all of a sudden, this patient has a straight toe, and an ulceration heals. Now, the difference for him specifically, he's already lost his second toe. Let's say he decided to amputate that third toe, which would be, salvage in some respect. What is he left with? A first toe, a fourth toe, and a fifth toe. He's going to have increased pressure with those third and fourth metatarsal heads. He's going to have increased pressure with the fourth and fifth, the fourth of the toes. He is asking for another procedure. So just by being able to straighten his toe with a 2-minute procedure, we now save this patient a significant amount of stress and work. So again, if you see a recurrent ulcer at the tip of the toe, before you lop it off, see if you can straighten it. And if you can straighten it, and you haven't yet learned how to do a tenotomy, send it to someone who can, because you are going to save that person's toe just by making it work. And our last one, this is David. He's a farmer. He's come in, unfortunately, with what we're going to call a surgical emergency. Elevated temperature, elevated heart rate, elevated blood glucose. His white blood cell count's through the roof. His A1C sucks. He's got decent vasculature, right? Enough to bring him potentially do something. But this is what he comes in. Okay? So just based on this, how many people have seen a patient like this? A few. So I'm going to pick on you because you raised your hand. So this patient comes in. What was done for a patient like this? What would you do? Disarticulation. What would you disarticulate? The second? The third? Good, what else? close it up, and we send them home. Success, right? Yeah? Yeah, right. You know, you closed it, you got rid of the problem, done deal. So you're not wrong. We just articulated. Surgery is indicated. This person is coming in at a surgical emergency. There's gas in the tissue. There's crepitus under the tissue. There's gas on the x-rays. His vitals are out of whack. Yes, you need to do surgery on this patient, but you are not going to heal this patient with one procedure. So what do? Yes, you just articulate the toes. Yes, you do an amputation, and then you pack it, and you leave it open. We let it settle. Why? Remember, we need to stage a procedure. Not everything is solved in one procedure. We want to make sure we figure out what's viable and what's not viable. So we wait. Sometimes it's 2 days, sometimes it's 3 days. Sometimes they need a second debridement because some tissue is non-viable. But we need to figure out what is viable before we stage this patient. Okay? So on the first night, you do all the good medical stuff, which I will go into detail about. What you could do in terms of surgery, the guillotining, debridement. So you're taking off the second, third, and fourth toes in situation and metatarsal next. You are releasing everything that has gas in it. And then you're waiting. You're treating them medically, waiting for that to sort of heal up and demarcate. Once that has happened, that's when you go in for stage 2 and say, okay, now we have a clean tissue, we have viable tissue, this is how we put it together. And because I mentioned the TMA about 30 times, that's what this patient's going to have. Transmetatarsal amputation, because we don't want to leave them with their first and their fifth toe sticking out, like a rock star. We want to make sure we give them something functional. So we do the TMA, we close it because now we know what tissue is good, what tissue is not. We address the equinus because this person had equinus because we did a silver skull maneuver, we figured it out. Now we've done all that in the next procedure, and we've created this nice little stunt. Okay? When this patient comes in and you have a gung-ho, I want to save the world surgeon, have the conversation of what do we want to do for this patient right now? What do we want to do for this patient in 5 days? What do we want to do for this patient in 3 months? What do we want to do for this patient in a year's time? This should be something that should be referred early, should be operated on early, operated on in stages. And then all the patients hopefully are all happy because you've done the right. So hopefully you've taken something away from that presentation, all the different presentations. Thank you guys all for your time. I know we're basically out of time, but we do want to leave a little bit for Q&A. So for anyone who has questions for any one of us, the whole panel's here. We'll let her rip. Any questions?
Right, guys, so we'll go around the room, we'll see if you guys have got any questions. I think what I'm going to do is ask the team to go up there, just grab a chair, go up there, and ask some questions. So I'll come around with a microphone, and you guys can ask any questions. Yeah, just, I think everyone should say to unless the team is still fresh, they don't stand. So.
Any questions from the right side of the room? No questions. There are questions? How about the middle of the room? Yes, you got a question?
Yes. Come with microphone.
When do you see that stop?
Okay, that's a really good question. You should look at what your antibiogram resistance, etc., is in your center. So a lot of the times, the easy thing to do is start off with flucloxacillin and amoxicillin, but it doesn't always work. Try to consider fluoroquinolone depending on the clinical status of the patient, and if not, third generation cephalosporin, like I said, triazole would go down very well with the patient. It's tolerated well, does not require renal dose adjustment as well. I'm thinking this patient would probably have multi-organ failure or is at risk of. Signs and symptoms, 1, 2, it's about the ESR and the CRP as well. You want to start, you want to switch over from IV to oral only if there is a downward trend and if the clinical picture is much, much better. There is no set timing. There is no such thing that you have to give medications and IV antibiotics for 5 days and 5 days only. In the meantime, please, culture sensitivity is absolutely necessary. You know, he was waiting to say that. The best way to do it is a bone biopsy.
If there's exposed bone, don't just do a bone biopsy because the gold standard if there is no exposed bone.
And
I've seen that happen. Not good look.
but that doesn't mean that it's like he said. It's not only bone biopsy. A culture tissue, even a tissue biopsy. Next best thing is a wound swab. So you clean the wound a little bit, go as deep as possible, swab, put it in the container, send it right away to the laboratory. Make sure you follow up that culture sensitivity because this is where AMR comes in or antimicrobial resistance. Osteomyelitis, Samir, between 6 weeks of oral and 6 weeks of IV. Lots of guidelines saying that it's almost the same, but of course it depends on the clinical manifestations of these patients. What's your opinion?
So my opinion with if you're dealing with osteomyelitis, as a surgeon, generally osteomyelitis in my world is something that I want to get rid of. So we talked about the other bony procedures that are available, exostectomies, internal amputation, so metatarsal head resection. In the situation that allows me to remove that infected bone, I will remove the infected bone and then continue on with the course of antibiotics after that. Usually at that point, we can go to oral antibiotics for 4 to 6 weeks afterwards, depending on what the CNS comes back as. However, again, language matters. If you have a person living with diabetes who has bone infection and they haven't quite wrapped their head around having some sort of surgery, or let's say they're not able to have a surgery from a costly perspective or from a management perspective, and antibiotics are an option, then I lean towards the 6 weeks of IV antibiotics, followed by a 6-week course of oral antibiotics, depending on how those labs are. But again, I'm not an internist, I'm not an infectious disease doctor, and so this is where I would defer to my multidisciplinary team and say, I don't know jack about this. What would you do? Because I'm not cutting on this patient. And that's where they would come in.
I hope we've answered your question.
Yeah,
On the other hand, I'm going to ask you one more thing regarding the same patient. That's why. What do you think about antibiotic granules, the calcium sulfate or magnesium sulfate? I mean, it's not easily available, but it should be an option. You should know about it.
So if we're doing, let's say you're doing an amputation or you're doing a resection. So for example, the gentleman that the last case that we did a disarticulation guillotine, and you're going to stage this procedure, there are many people who will put antibiotic granules into that wound while it's left open. I have no issues with that. In my practice, or when I was in Canada and studying in the US, I didn't see a large difference in outcome when we were staging that procedure in the short term. When we were taking this patient back to the OR, multiple times treatments, demarcation, getting viable tissue, the antibiotics locally in the granules didn't have much of a difference. Where they mattered is when we were staging the patient longer term. So they were going away or sent home for a period of time, and we were partially closing that wound. We would do so with granules into the antibiotics, and then bring them out for the definitive closure later. We have had good success with it. I still personally have to wrap my head around it, whether or not it was the granules that actually did it, because this patient also went home with IV antibiotics and were getting infusion on a daily basis. So I'm still mixed bag about it.
When it comes to, again, evidence-based, again, this is what I keep saying. Evidence is basically, a lot of the evidence comes from the Western guidelines. And we don't know what works well in our setting, with our skin, with our population, we don't know. So would I try it? Is it available in Kenya? Yes, it is. So have that conversation with your surgeons and ask them about the antibiotic-infused granules, what their experience has been. Because I have seen with a couple of patients, I've tried it out, I have bone graft. It's calcium alginate? Sorry, when I remember what that exactly is, I'll remember and tell you. But we mix it with gentamicin, depending on the culture sensitivity report, of course. And we used it. The exudate significantly came down for this patient. And then we referred. By the meantime, this patient was able to accumulate enough money, then we were able to refer to the surgeon. That is always the mainstay. As much as I say I don't like surgery, when it is needed, life over limb, 1, 2, like he said, it is staged. It is about a conversation that you have with the surgeon, and then you understand and you talk as a team to the patient. It's multidisciplinary. One person can't fix everything or explain everything. It has to be together.
Yeah, I just wanted to ask Kennedy a question. They're talking about culture and sensitivity, right? When should you do a culture and sensitivity? When you're presented with the wound and it's a mess? Or I would like you to just clarify that, because a lot of people always ask the question is, when do they do a culture and sensitivity? When do they take a swab? At what point,
At what point?
when you're dealing with an ulcer, do you take a swab?
Okay. When dealing with infections, remember, uh, this is something that can be progressive. Like, we have different stages of an infection. There is local infection, whereby the infection is just localized on the wound. We have spreading infection. You can be able to map out manifestations of infection in the peri-wound skin. And then there is systemic infection. These particular individuals showing signs and symptoms of an infection. So the moment you identify an infection, ideal way is normally to take a swab as soon as possible, so that you can be certain of what particular bug you're dealing with. And then it will also be in a position to help you know what time to give an antibiotic. For instance, local infection, we manage them by local antimicrobial dressings. That is simple. But when you're having spreading infection or systemic infection, that is when you need to introduce systemic antibiotics. So before you introduce systemic antibiotics, it's good to know what particular antibiotics you're giving, and that will be guided by culture and sensitivity. Do a wound swab, do culture sensitivity. So local infection, if the antimicrobial dressing is not appropriate enough to take care of local infection, then the right thing to do is to do a wound swab and progress on to manage with the appropriate antibiotic.
Thank you, Kennedy.
Good.
And the other thing I was going to say is, when you take a culture and sensitivity, make sure you clean the wound first. You don't take it when it's a bacterial soup, because you'll get cross contamination and you won't get an accurate culture. So remember to clean the wound gently with normal saline, and then you go as deep as you can into the center part of the wound, into the deepest part of the wound, and you take a proper swab. So just remember that. Thank you, Kennedy.
Good. So I first want to thank all the speakers for their excellent talks. So maybe you can guide us. We have all these reps coming to offices about all these new wound care agents that claim to enhance granulation tissue and enhance regeneration, collagen, and there are so many in the market right now. What's your take? What's your advice? Because there are so many. I think there are like 6 products now in the market which are aggressively being marketed. So just please give us guidance as physicians, nurses. What should we use for wound care?
Okay, very good question. I get the same headache as well. Like, there's a lot of new things in the market. Point to take note of, we're talking about the science behind wound healing. What is necessary to make changes, that cellular change, and ensure the wound is healing appropriately. We know a lot of fancy products, they've been given fancy names and everything. You think about, hear a name and you like, this is going to do magic. Huh? The science of wound healing is the same. Remove non-viable tissue, manage infection, balance your moisture, how are your edges, how is the surrounding skin, how is the patient status, is the patient in a good host for the wound, like will the patient be able to encourage the wound to close. So if a product is not going to do all these things, like stimulate granulation, help with debridement, help to balance your moisture, ensure the edges are advancing, then that is not an appropriate dressing. So whichever product they come, look at a monograph, do case studies, don't just purchase because it's available in the market. Make sure you put these products to test, because at times cost is a factor to the patient. Like, make sure by the time you're having this patient purchase this product, you're able to prove its efficacy. So not all products out there are good. Let me just tell the truth. Not all products are good. Some are just some placebos with names to make things work, or whichever thing. Get monographs. It's going to help, like, give good outcomes to the patients. Good.
I have a small opinion about this. As much as a collagen and all of that becomes quite expensive to use, there are certain things that are available in the market, which might seem a little outwardly, but they actually work. One of this is a topical oxygen therapy. Topical oxygen therapy works. It is proven. It is part of the IWGDF guidelines as an adjunctive therapy. A collagen has not yet been adapted completely into the guidelines because there is not enough evidence. So, like he said, it's time. It's the management. It's keeping a clean wound bed, and it's moisture management. It is the most basic and the simplest and the best thing you can offer to your patients. The
And
rest
it-
of the dressings work sometimes, but
Just he's at the back.
no, that's the thing. So, I mean, so it's again, topical oxygen therapy is something that I can say that for sure there is proven evidence that it stimulates, like he said, unless it stimulates granulation tissue, and oxygen therapy does. It makes a huge impact. I've seen wounds healing over 5 to 6 weeks, 2 hours or 3 hours twice in a week, and they do so well. The continuous oxygen therapy is proven to be part of the therapy, and it really makes a difference. Just this opinion also.
Is it available in
Yeah.
Kenya?
Yes, in fact,
yes. Dr. Jenga,
Okay.
the gentleman at the back.
Yep.
Just put your hand up.
Mr. Mudaida is in the back.
Go and have a chat with him. He'll talk to you about
Yeah.
oxygen
Okay.
therapy.
He has a
Yes.
device that actually continuously.
Maybe you can come forward.
yeah.
Just tell us briefly about what it does, just briefly, a few. So where can we access, if I was to refer a patient for oxygen therapy, where can I send a patient in Kenya?
Okay, well, I know I use it in my practice on a regular basis, but I think Mr. Mudaida will be able to guide us on where else we can get it.
Okay.
Because he has a beautiful device. I have utilized it.
Okay.
It has brought about some good results in my patients as well. And maybe he can tell you a little
Okay,
bit
so
more
let's,
about it.
in summary, what the device does.
Okay, thank you. My name is George Mdaida. I work with MSG Medica. So what we have here is, like what Dr. Shilpa says, topical oxygen therapy. What it does, it takes the ambient air, passes it through zeolite, and at the end of the pipeline, you get pure 95% pure oxygen. Now, this is more of a targeted therapy where it directly takes the oxygen to the wound bed, as opposed to, let's say, hyperbaric chamber where the whole person is exposed to oxygen. The wound is directly exposed to the oxygen. In addition to that, this is continuous. If you take a patient to the hyperbaric chamber, the patient will be exposed to the oxygen for around, let's say, 90 minutes. But this one is for 24 hours, and it runs continuously for 24 hours for almost 15 days. And this one also, it's rechargeable, and it's available in most of the pharmacies around. It's a practically new device, but we are getting it available. Thank you.
So I think you can go and talk to him. He'll be at the back and he'll take any questions. So thank you, sir. Appreciate it.
Okay.
So since we are talking about that from the surgeon, VAC dressing. So I'm an endocrinologist. We have a lot of diabetic, diabetic wounds are cumbersome, amputations, repeated debridements. What is the indication for a VAC dressing? What should we watch out for when someone has a VAC device? And how long for which kind of wounds, VAC dressing?
So good question. Before I jump to that, I'm just going to answer your last question in terms of one other thing. And reps don't like me for this reason. There's lots of great dressings out there. There's a lot of good wound care products out there. Don't become reliant on one product and say, hey, I've got this new thing. It's awesome. It's the newest thing. And forget about all the principles that Kennedy talked about. If you're putting this on, but you're not actually adequately debriding, or you're not using something that's going to help you debride, or you're not using what Dr. Hafsa told you about offloaded, all those topical therapies essentially become useless. If the wound is wet, know how to dry it. Have a few things in your bag. If the wound is dry, know how to maintain that moisture balance. Have a couple things in your bag. If you can't debride it yourself, have a couple of tools that allow for, let's say, enzymatic debridement. So researching a couple in each category to help with the principles of wound care become very, very important. So just look at all the different products, but take it with a grain of salt. That one by itself is not going to be your end all be all golden chariot for this. For the VAC, great tool. It's something that is an underutilized dressing that we should be using more of. So where I use a VAC personally is if we have any wound that has some depth to it and I need to bring up the granulation tissue from a deep spot. Now, we try to always manage the infection, so we're managing infection concurrently. Some people don't like to put VAC over top of bone immediately. I'm okay with putting VAC over top of bone if we're trying to stimulate granulation tissue over the bone, as long as you're treating that infection concurrently. There's not a timeline that I put VAC therapy in. The reality is VAC therapy, when used effectively and stimulating granular tissue to form, you're creating a bed not to close the wound necessarily, but to allow it to accept a different type of closure later, whether using a split thickness skin graft or an advancement flap or a reverse Searle or whatever the case may be. You're creating that good wound bed when local foot care is not doing it fast enough, or you're hit at a stagnant point. So whether it's 2 weeks, 4 weeks, 6 weeks, 4 months, it's still a very, very viable option, assuming you're getting continuous formation of that granular tissue. And it really depends on the type of the wound.
Any other questions? Just raise your hand.
I just have one thing on offloading as well to Dr. Hafsa. So, you know, what percentage of a wound, so the percentage of a wound that's healing, how effective is offloading in relating to what percentage of that wound should heal? So people say 30%, the wound will heal at by 30% if you offload it, but it's more than that, isn't it? So why is offloading such an important tool in the whole context of wound healing?
Well, providing the circulation is fine and you're using the right offloading material and there are no other complications, it should heal 100%, right? When it begins to deteriorate further, then you need to rethink what you're using, also reassess the patient, see if there are any other underlying problems, or even, you know, chat with the wound nurse, see what's going on. But offloading generally should work, providing everything else is also being addressed.
Thank you. The definition of insanity is wearing the same shoe with an ulcer that you wore in with the ulcer, and then going away, having the wound healed, and then coming back with the same ulcer with the same shoe on that you had before that caused the same problem. So footwear here is also incredibly important. That's why all of us podiatrists wear trainers, as you can see. Who's the question over here? Question? Okay, question?
Thank you. It's kind of a simple question, so I don't know if this is the right place to ask, but patients often ask what they should eat when they have a diabetic wound that's healing. So I don't know if you have any recommendations on what patients should eat, because I usually don't know what to tell them. Thanks.
So individuals who are living with diabetes-related foot ulcers are in a catabolic state. That means they require more carbohydrates than would generally advise for an individual who's not living with a diabetes-related foot ulcer. You have to adjust the insulin, the medications to make sure that the sugars remain normal, but the nutrients, micronutrients are improved. So a higher protein, slightly higher protein diet, a slightly high carb diet because they're in a catabolic state, but also micronutrients are required. Your vitamin B12, your vitamin D are essential, and they are research-based or rather guideline-based therapy. But when you add on the rest of the multivitamins like selenium, chromium, these all behave like they're anti-inflammatory, reduces insulin resistance, improves insulin sensitivity, promotes an environment of wound healing. There's also a little bit of evidence on trypsin bromelain. There's a couple of brands out there available as wound care supplements. There's no harm in giving it, but if I have to give you one line and you can give one line to the patient, eat an egg every single day. 1 egg minimum. Even if it's 2 eggs, it's okay if it's 2 egg whites and 2 egg yolks, it's fine. But at minimum, 1 egg a day is the least we can advise.
Lead with that. lead with that for sure. I think that's great advice. I wouldn't lead with the more carbohydrates is good for you, because they may just go grab a Coke and technically fall into that category. So complex carbohydrates, and start with the protein. That's a very, very good advice.
And just to add on, so remember, very, very good advice. But remember, any patient with a wound, remember, they have to monitor their sugars more frequently. Glycemic control is key to wound healing. So as much as we've discussed several aspects of wound healing in terms of moisture balance, glycemic control is very, very important. So let them have their targets and tell them what their targets are. Fasting sugars, 5 to 7. Ideally, post-meal sugars between 5 to 8. So if you're going to adjust their diet also, that means also you have to adjust their insulin requirements, but they have to monitor more. You can't have someone come into the wound clinic 3 times a week and they tell you they're checking their sugars twice a week. It's counterintuitive. Frequent monitoring, adjust your insulin doses, let them talk to the nurse educator, very, very important. And more frequent visits to the endocrinologist or the diabetologist until the wound heals. We have to stress that particular point. Jacinta here is our...
The wrong tools, you can either increase that ulcer, make it deeper, or cause an ulcer in another spot. So it is important that you monitor this patient regularly, but also educate the patient. They need to be aware of what to look for. They need to be aware of what red flags can happen. Because ultimately, you can't guarantee that a small piece of felt is going to fix the ulcer. You've got to monitor them, see how they're going, see how they're reacting to it, and then make decisions based on how they're going. Yeah.
Oxygen therapy, timing.
Very quickly, when everything that he has said in place, your moisture balance, clean wound bed, everything that Hafsa has said, where there is offloading in place, everything that Dr. Samir has said, there is no surgical indication at this point in time. This is a clean wound bed. It's taking a little longer to heal than usual. It needs a little bit of a push. Then you can use topical oxygen therapy. The way I do it in my clinic is very different. I have not documented the process, and I know that it works, but I have not been able to kind of put it together in a way that I can tell you how to do it. I'm yet to do an analysis of all the cases that I've done, and then I can give you research-based evidence. I can't talk from experience alone. It's wrong for me to guide you from experience alone. I need to have concrete evidence and analysis that this is working. Clinically, yes, it works. Topical oxygen is in the guidelines, yes, but these are the indications and contraindications. Contraindications is an infected wound bed. And when I say infection also, please remember IWGDF, IDSA guidelines of infection. Look at those and then classify your wound. It's not only about superficial deep, it's about the spread.
So on that note, if we have any really burning questions, I just wanted to wrap up now, because I know you guys are probably going hypoglycemic and need something to eat. So I was just going to say, I'd like everyone to just give one take-home message for our panelists, and then I will just say one more thing, and then we can wrap up, and let's keep walking. Thank you.
My take-home message is Jacinta has a question.
Last question.
Last question. You talked about good footwear, right? How am I supposed to know that I'm wearing a good footwear? Despite of me wearing or buying trainers, when I'm buying a trainer, how am I going to know that this is the best trainer that I'm going to buy?
By Air Jordans.
So footwear, basically, always buy shoes in the afternoon. Make sure they fit comfortably straight off the bat. Don't buy something that bites your foot, because it will eventually break your foot, particularly if you're a diabetic. So remember, shoes at the end of the day, make sure they fit comfortably straight away. They should fit like a glove. And if they don't, you are leading yourself to a serious problem, and particularly if you're a diabetic. They should fit. And for ladies, nothing over two inches. And make sure it fits and it's wide enough at the front. So like if Dr. Shilpa stands up, that is not what you should be getting. Okay. So on that note, Dr. Samir, would you like a take-home message for us, please?
Take-home message.
Regarding foot surgery.
From a foot surgical perspective, my one take-home message for you today would be to change our mindset for surgery from an ablative way of thinking. This is not an end stage to a reconstructive way of thinking. What are we doing for our patient? Not today as an endpoint, but in the future for the rest of their lives.
Thank you. Made that easy for me. As a physician in a multidisciplinary foot and wound clinic, my role should be more proactive than reactive, teaching every patient who comes to me living with diabetes regarding foot care, every time they walk into my clinic, looking at their shoes, judging them, blackmailing them into getting better footwear, 1. 2, telling them to look at their feet before they go to sleep every night so that they get to know what their feet look like. And good glycemic management, metabolic control, infection management, key multidisciplinary approach. It's not a one-person job. It's all of us here together. Nobody trumps over the other. And of course, please know newer therapies. Don't be shy of newer therapies, but learn what the guidelines say and do research.
Just to echo as well what came out from our discussion today, remember, wound care products, just like any other medication, this is treatment. So not a particular product suits all wound status. You have to keep shifting according to the wound status. So it's good for you to know the indications of each material before you apply it on a patient, so you can be able to make the best out of that particular dressing material. So just like any other medication, you don't use malarial treatment to treat skin diseases, same thing. Not all wound care materials goes in different wound status. You have to keep switching.
All right. Well, mine is quite simple. Offloading is definitely part of wound care management. Please use it.
And mine is to thank Kdsg for allowing us to come here today and present, to thank my team for the wonderful work and everything that they've been doing, and thank you for your excellent presentations. Let's treat the whole patient, not just the hole in the patient. And remember, the foot is like the donkey of the body. It gets treated with, it does all the hard work and gets